Welcome to this episode, where we're diving deep into female reproductive anatomy, conception, embryonic and fetal development, and the complexities of managing high-risk pregnancies. This discussion is grounded in a comprehensive quiz prep document designed to sharpen clinical knowledge for advanced nursing practice and maternal-fetal medicine. So let's get into it.
Absolutely. Starting with fertilization and ovarian function, it's interesting how fertilization almost always happens in the ampulla, that outer third of the fallopian tube. It's such a specific site, but it makes sense given the environment there is optimal for sperm and ovum interaction.
Right. The ampulla provides the right conditions, like the right pH and secretions, to support fertilization. And the ovaries play a dual role here, not just producing the ovae, but also secreting key hormones like estrogen and progesterone. These hormones regulate the menstrual cycle and prepare the endometrium for implantation.
And don't forget the LH surge, which is the hormonal trigger for ovulation. That sudden spike causes the mature oocyte to be released from the follicle. It's a finely tuned hormonal dance.
Exactly. Moving on to uterine anatomy, the uterus has three layers: the endometrium, myometrium, and perimetrium. The myometrium is the muscular middle layer, responsible for contractions during labor.
Yeah, the myometrium's contractile function is crucial for delivery. And the decidua, which is the modified endometrium during pregnancy, supports implantation and placental development. It's fascinating how the uterus adapts structurally and functionally.
Speaking of the placenta, the chorionic villi are key structures, those finger-like projections that extend into maternal blood spaces to facilitate nutrient and gas exchange.
Right, and the chorion forms the fetal side of the placenta, while the maternal side comes from the endometrium. The umbilical cord itself contains one vein and two arteries. The vein carries oxygen-rich blood to the fetus, and the arteries return deoxygenated blood to the placenta.
And the umbilical vessels are protected by Wharton's jelly, which acts like bubble wrap around delicate wiring. It cushions and prevents compression, ensuring continuous blood flow.
That analogy really helps visualize it. Now, fetal circulation is another fascinating area. There are three critical shunts. The ductus venosus bypasses the liver, directing oxygenated blood from the umbilical vein straight into the inferior vena cava.
Then the foramen ovale allows blood to move from the right atrium to the left atrium, bypassing the lungs, which aren't functional yet.
And finally, the ductus arteriosus connects the pulmonary artery to the aorta, further diverting blood away from the lungs. These shunts are essential adaptations for fetal life, where oxygenation happens via the placenta.
Exactly, and after birth, these shunts close as the lungs take over oxygenation, which is a critical transition.
Shifting gears to embryonic development, the three germ layers, ectoderm, mesoderm, and endoderm, each give rise to specific tissues. The ectoderm forms the nervous system and skin.
The mesoderm develops into muscles, bones, and the cardiovascular system, while the endoderm forms the gastrointestinal and respiratory tract linings.
The ovum stage lasts from conception to day 14, followed by the embryonic stage, which is the most vulnerable period for teratogenic effects.
Right, and then the fetal stage focuses on growth and maturation of organ systems. Understanding these stages is crucial for assessing risks during pregnancy.
Speaking of pregnancy, the signs are categorized as presumptive, probable, and positive. Presumptive signs are subjective symptoms like amenorrhea and nausea.
Probable signs are examiner-observed, such as Goodell's sign, cervical softening, Chadwick's sign, the bluish discoloration of the cervix and vagina, and Hagar sign, which is softening of the lower uterine segment.
Chadwick's sign's bluish hue is due to increased vascularity and venous congestion, which is a subtle but important clinical clue.
And positive signs provide definitive evidence of pregnancy, like fetal heart tones detected by Doppler and ultrasound visualization.
On the topic of due dates, Naegele's rule remains a standard method. You subtract 3 months from the first day of the last menstrual period, add 7 days, and adjust the year accordingly.
For example, if the LMP was August 20th, 2025, the estimated due date would be May 27th, 2026.
Moving to obstetric history, the GTPAL system is a handy mnemonic: gravidity, term births, preterm births, abortions, and living children.
So G4T1P1A1L2 means 4 pregnancies, 1 term birth, 1 preterm birth, 1 abortion, and 2 living children.
Amniotic fluid also plays a vital role. It cushions the fetus, maintains temperature, and allows movement. It's produced by both fetal urine and maternal plasma.
Abnormal volumes can indicate pathology. Oligohydramnios, or low fluid, is often linked to fetal renal abnormalities, while polyhydramnios, excess fluid, is commonly associated with gastrointestinal obstructions.
And oligohydramnios increases the risk of cord compression, which can have serious implications for fetal oxygenation.
Hormonal dynamics are equally important. Human chorionic gonadotropin, or HCG, is the hormone detected by pregnancy tests and supports corpus luteum function early on.
Human placental lactogen increases maternal insulin resistance, ensuring glucose availability for the fetus.
Progesterone maintains the endometrium and prevents uterine contractions during pregnancy, which is essential for pregnancy maintenance.
Now, high-risk pregnancy complications are a major concern. Severe hypertension is indicated by a blood pressure of 168/112.
Preeclampsia is characterized by hypertension and proteinuria, with worsening signs including persistent headache, blurred vision, and right upper quadrant pain.
Eclampsia involves seizures in a preeclamptic patient, which is a medical emergency.
HELLP syndrome, hemolysis, elevated liver enzymes, low platelets, is a severe variant requiring urgent intervention.
Magnesium sulfate is the drug of choice to prevent seizures in severe preeclampsia, and calcium gluconate is the antidote for magnesium toxicity.
Gestational diabetes increases risks of macrosomia and neonatal hypoglycemia, with diet and exercise as first-line treatments.
Placental disorders also differ clinically. Placenta previa presents with painless, bright red bleeding, whereas placental abruption presents with painful bleeding and abdominal pain.
Multiple gestation increases the risk for preeclampsia, which adds complexity to management.
Regarding fetal lung maturity, lecithin is a phospholipid critical for surfactant production. An L/S ratio of 2:1 or greater indicates mature lungs.
That's a key marker to assess readiness for extrauterine life and reduce respiratory distress risk.
Finally, twin pregnancies. Monozygotic twins result from division of a single fertilized ovum and are genetically identical.
Dizygotic twins come from 2 separate ova fertilized by 2 sperm and are genetically distinct. Twins may or may not share a placenta depending on timing.
Before we wrap up, some high-yield memory tips. Presumptive signs are subjective, probable signs are examiner-observed, and positive signs are direct evidence.
Fetal circulation shortcuts. Ductus venosus bypasses the liver. Foramen ovale bypasses the right atrium to left atrium, and ductus arteriosus bypasses the lungs.
And for placental bleeding, remember previa equals painless bleeding, while abruption equals painful bleeding.
Plus, severe preeclampsia warning signs include headache, vision changes, right upper quadrant pain, severe hypertension, and hyperreflexia or clonus.
That's a lot to take in, but these details are critical for clinical practice and patient safety.
Absolutely. Understanding these concepts deeply informs nursing care and patient education, especially in high-risk pregnancies.
Thanks for exploring this with me. It's been a thorough and insightful discussion.
Likewise. Until next time.